Okay, so I think most people on this talk know who we are, but in case anyone's watching the recording, I'm a clinical psychologist at Eskenazi, and Adam is a clinical supervisor. So we are mental health providers at a large urban community mental health center. We work with interdisciplinary teams and treat adults with serious mental illnesses who face the largest number of barriers in Indianapolis. So Adam and I have unfortunately experienced many client deaths and had to navigate receiving this news in various ways, sharing it with staff members and processing a bit afterwards, which got us thinking about the importance of this experience of client loss. We both have been touched by client deaths, both with clients on our teams and with people we've worked with directly. So we think it's important and wanted to talk about it. And we hope that you find it important too. We'd like to add a disclaimer that neither of us are experts in the area of grief and loss, but through sharing our experiences working at the CMHC and encountering death more than we would like to, we were just hoping to stimulate some discussion and reflection with other therapists and help to combat the stigma surrounding conversations about death. We also thought it would be a good fit of a topic for merit because merit is a meaning-making approach and emphasizes the relationship. So we thought it might be a good context to think about this. So by the end of our talk, we are hoping that you will be able to describe and normalize the experience of losing clients and grieving for them, regardless of what the cause of death was. Utilize some concrete strategies when supervising people who've experienced the loss of a client, identify barriers to grief and meaning making in a community mental health setting, apply an integrative framework to help make meaning through client loss, and promote some discussion of this shared experience.
So Jackie introduced us a little bit. Most of you do know us. I think just one point to add there. So the team that I supervise is an intensive adult outpatient team, which historically has been operating under an assertive community treatment model, and again is so we do a lot of meeting with people out in their homes, seeing them out in the community. And I think, as many of you do, we've noticed that sort of in line with the statistics that our clients tend to die as much as 25 years average, sooner than the general population. They have an increased risk of victimization, homelessness, dangerous lifestyles, uh, chronic health risks, very low ability to follow up with physical health concerns, difficulties navigating really complicated bureaucratic systems in order to access healthcare. Uh, People are on antipsychotic medications for a long time that oftentimes do affect their general health, and that really commonly people, when they do get in front of a provider for some kind of physical care, a lot of times those symptoms are attributed to their mental illness and not given the appropriate attention. And the research around grief and mental health workers is that it does affect us all in negative ways, but also positive ways as well. And we'll hope to talk through a little bit more of those throughout our time here. But one thing to highlight, sort of in my team in particular, is that sometimes our role starts in these when we discover the client who has died, because in many times we are the only ones sort of populating their lives, who are likely to come and check on them.
Okay, so I'm going to start off using a case example of one of my clients, and then talk about the clinician reactions to losing clients. NASH is a pseudonym, so to note, any client information that we use in this talk has either been changed or de-identified, and all of our clients sign a general consent to treatment at the beginning, allowing us to use their information for research and education purposes. So Nash was my first therapy client of my career. I was lucky to be able to work with him for 5 years for therapy. He had a serious mental illness. He was pretty isolated and estranged from all of his family. He lived on his own, but he frequented local businesses and chatted with people there every day. He was an artist and often commented that his art would be his legacy. He rarely missed our standing weekly appointments and told me that he shared things with me that he had not shared with anyone before. Unfortunately, Nash died suddenly. His cause of death was unknown, and I found out through a phone call from my boss when I was on vacation. There was no funeral or anything. He didn't have any relatives, but there was a brief obituary for the public, just kind of generic information. So thinking about initial effects on the therapist, let's talk first about emotional and cognitive responses. Of course, these will differ for everybody, but there are some common themes. When looking at nursing students who worked a lot with people who had died, themes emerged of feeling helpless, loneliness, anger, and guilt. Also, this idea of the therapist retracing their steps, so trying to identify if there's anything you could have done differently to prevent that outcome. The circumstances surrounding the death might also impact how you respond to it. So the area model listed here suggests that we have the strongest emotional responses to client deaths that are novel, unexpected, uncertain, and self-relevant. So with Nash, his cause of death was unknown. And personally, it made me feel better to think that it was COVID because it was during that time of lockdown. In my mind, he passed peacefully in his apartment, and then someone working there found him at some point. I actually have no idea if that's what happened, but it gives me more closure than imagining something more painful or difficult. Now, when a patient dies by suicide, there is more to grapple with than grief alone. There's a lot more research on this specific experience, and so I won't go too much into it. But some common themes that emerged in addition to feelings of grief included professional guilt and shame, fearing judgment from colleagues, worrying about like risk management and legal liability concerns, as well as feeling ambivalent about sharing the experience with other people. Thinking about the therapy relationship, this might vary slightly by therapeutic orientation or model, but our emphasis on the alliance and the therapeutic relationship can kind of blur this experience of genuine grief with like something that happened at work. So this could be hindered by like a traditional view of the therapist as a blank slate, but this is a real human relationship that you have. So I remember being surprised by how much my reaction to losing Nash felt like a personal loss, and thinking like, this is part of my job. Why am I having such a human reaction to this? Another prominent experience is a sense of isolation. So due to patient confidentiality, there aren't many people that we can share this experience with while it is happening. Again, I remember wondering if the employees at the businesses that Nash went to would notice his absence, wanting to like go there and tell them what happened or talk to them about him. I also remember feeling this sense of responsibility for properly grieving his death because other people would not be. And thinking about therapist factors, many things can affect how you grieve. So as a therapist, your own like cultural background or view of grieving practices, your religious and spiritual beliefs, your relationship to the person who died, your own mental health, as well as previous experiences of grief, perhaps in your personal life. So finding meaning from loss, both making sense of the experience and identifying some benefit despite the pain, is found to play a critical role in adjustment following loss and trauma. So in our research, we found that there are things that promote and also things that hinder the meaning-making process. So some things that seem to help are first acknowledging, reflecting on, and sharing grief reactions. Elizabeth Kubler-Ross, in her book on grief and grieving, emphasized the importance of storytelling. She said that grief must be witnessed and shared to be healed. And again, there's still those limitations to this, given client confidentiality concerns and who we are allowed to share those stories with. If your work setting is conducive to a more formal meeting, you might benefit from gathering people together who had worked with the client to maybe allow some space to process the loss or encourage connection, storytelling, kind of honor the patient's life and your work together. We've done this at our community mental health center, and it's generally been a positive experience to have some closure with the loss or share memories with people who also knew the patient. But again, there's going to be individual differences to this. Some people might want to participate in that. Some people might want to just go and listen. Other people might not really want to do something like that. And of course, that wouldn't be something that should be mandatory, but maybe helpful to offer that opportunity if you're able to. And the factors that hinder, you'll notice some similarities related to avoidance. So both avoidance around talking about the loss and avoidance of the grief feelings themselves. So it makes sense as a human to want to avoid pain, right? It can be uncomfortable for us to face our own mortality. The problem with that is that avoiding it doesn't make it go away, and the avoidance might even restrict our ability to understand or be aware of our reactions and how they come up with patients or in our work in the future. Unrealistic positivity is on there because generally in our work as therapists, we want to focus on helping to make a patient's life better. So it might seem counterproductive to think together about the end of someone's life, but death is a meaningful part of life as well that should be attended to. Okay, and next, thinking toward the future, losing a client might impact the way that you view other patients, the way you view yourself as a therapist, and the way that you view the work that you continue to do. So you might notice an increased awareness of the humanity and vulnerability of your patients, which could lead to feeling more attuned to them and the work, but could also potentially pose a difficulty forming attachments with subsequent clients if you're holding on to this lingering fear of loss. After loss, you might also be more likely to view your clients as like vulnerable or fragile or unsafe, further contributing to the stigma that already exists surrounding mental illness. All that to say that these reactions are very common and normal, but may be important to be mindful of if they're coming up in yourself or possibly work through in supervision or your own therapy. You might find yourself talking more or less proactively about death with clients following a loss. This is strongly encouraged by therapists such as Irvin Yalom, who directly advises people to confront death with their patients, given that it is such a central part of life. Providers working with people who have like advanced medical illnesses also found benefit from approaches that emphasized open dialogue about illness and their prognosis. This might not always be relevant to the work that you're doing, but again, fear or avoidance of these discussions on the part of the therapist can collude with the patient's desire to avoid the topic as well, even when it might be important to address. Another reaction that you might have to the loss of a patient involves adjusting your open interpersonal stance. So an open stance is thought of as a flexible, collaborative relationship within which you can think together and make meaning and resist attempts to direct or control the patient. So following the suicide of a patient, therapists were more likely to be reactive to clients reporting thoughts of death or suicide and quicker to initiate hospitalization. Other closed stances that you might feel pulled into might be to overly advocate for someone rather than helping them find ways to advocate for themselves, or explicitly discouraging risk-taking that might be healthy and essential for recovery. In thinking about losing the clients that we're working with, I like the notion that we are now the holders of some of these stories that they've shared with us, and the loss then becomes part of the therapist's narrative now, which isn't completely a negative thing. These are some ways that you can maybe carry on that narrative. So anonymously sharing tidbits of the patient's story with other people, other patients, maybe to instill hope or demonstrate an intervention. You could find a meaningful way to memorialize patients through trinkets, artwork, books, food, whatever it might be. For Nash, he had a book that he often brought up in his therapy. It was a Dr. Seuss book called, let me look. I Had Trouble in Getting to Solace Salou, which now is on my bookshelf. So in the book, if you're not familiar, the person is looking to get to Solace Salou, which is the land of no troubles. So throughout the book, the character encounters like daily inconveniences like weather, traffic, things like that. And then when they finally get to the land of no troubles, they find that the door is locked. And so they have to like turn around and give their troubles some trouble. And so that's what my patient would always talk about in therapy, how he was going to go and give his troubles some trouble. And so when he passed, that just really stood out to me as representing our work together. And so I got a copy of that book, and now it's on my bookshelf. So I see it every day in my office. And when people come in and see it and ask about it, it gives me a chance to talk about him and tell that story and kind of keep that as a meaningful way to remember him. You can not only reflect on the impact that you had on the client's life, but also the impact that the client had on your life and how they might have changed you or helped you grow in some way. And I know that most or all of us are therapists here, but another role that we might hold at some point is supervisor. And so moving on, Adam will speak more about ways that you could implement your experience of loss as a learning tool in supervision.
Thanks, Jackie. So last year we put out a paper really detailing some of our thoughts about what makes this moment as a supervisor in a community mental health center so challenging. Because I really do think that when a client has died and you're working with your supervisee to make sense of that and figure out what to do, that is one of the more difficult moments I think that we have. At first, it's really hard to figure out as a supervisor what kind of response do I offer. I think we all get plagued by doubts of like, how do I do the right thing? This is obviously a moment where I could mishandle this. We're all dealing with disenfranchised grief as mental health professionals who are explicitly or implicitly told in lots of settings that we shouldn't have strong grief reactions in these moments. We're also living in a system here where there's a real hyper focus on quantifiable outcomes. And then we're also challenged to find a way to balance meaning-making approaches with a really risk-oriented culture that we live in, where the management of risk oftentimes takes over in the clinical tasks. So I'm going to talk a little bit about those and share some stories along the way. And I think we didn't mention before, but the last third of this talk, what we're really hoping for is to have some time to talk together as a group with people's experiences and questions and thoughts. And so if any of this sort of sparks thoughts for you, please share those sorts a little later on. So the first thing to really figure out here is as a supervisor in the moment where I've just told my supervisee that somebody that they're working with has died, or they've just told me, or I've just found out. Uh, it, it's hard to know what to do. There is in the literature very, very little guidance about what a supervisor's job is in this moment. In doing research for the paper, I found guidance for podiatrists, for oncologists, for nurses, but very, very little as a clinical supervisor of mental health therapists. And so, lacking any formal guidance here, it's then additionally hard to balance that against what the supervisee wants from you. And in thinking about merit and thinking about agenda, uh, it's hard to know what somebody's own culture is with their grieving tasks. You might need to ask explicitly about these things to understand how you help them through this moment. And beyond that, you have your own confusion about what your role is as a clinical supervisor in a CMHC or in the VA or somewhere. A lot of times you wear hats like administrator, clinician if you have your own caseload. You might be a friend to the people that you supervise. Your job is also a risk manager, a compliance officer, an educator. You might have input on policy. You might be a productivity or organizational coach. And then above and beyond and behind all of these things, you might be just a similarly bereaved person who is also quite affected by this really tragic news you've just received. And so, in offering some recommendations to try to challenge that or to give some guidance in that area, we encourage people to start with just recovery orientation and shared meaning making, to think about the agenda and the relationship you have with your supervisee. So, similar in merit, you might in these moments try to think with the person about this as a narrative, as a story. You might try to encourage them to think through what they want from you as their supervisor, to offer them some opportunity to have a say in this response. We don't have a prepackaged answer for anybody about what you should be doing with your supervisee. Um, and I think the argument here is that helping people think through what they want and think through how to manage what's going on inside them as a supervisee uh, helps them to deal with future challenges that are likely to come in the same way. So I can think of staff members that I've worked with who have very different responses in these moments. I've had some people who very much just kind of want to acknowledge that it happened, end the supervision meeting early so that they can have quiet time to themselves before they return to a regular day of work, because they find that throwing themselves back into clinical work helps them move on or deal with it, but they don't care to share a lot of their reactions. I've had other people who really want to spend a long time thinking together about it, or who may not be able to return to work that day, or who don't want to, or need to be given permission to not return to work that day. Um, and beyond that, we think it's also important to remain open as a supervisor to new meanings that might occur. A lot of times, the people that we tend to work with serious mental illness, their lives are empty of other people. Uh, Many times, the mental health team is the group of people who populate their lives and who are most likely to check on them, most likely to notice their absence, most likely to have something like friendships with them. But after a death, sometimes families arise. You might, learn that your child or your client who you've had for many years had a child who you've never met and they've never spoken of, or a brother, or you might hear stories about them which don't at all fit with your knowledge of this person. And so part of the supervisor's job as well is to help people make sense of this as well. The next real primary challenge that I think people are running into is this one of disenfranchised grief, or where we don't feel eligible to have the full grief reaction. There's a really interesting dissertation, West 2022, where the researcher did some interviews with about a dozen clinicians who had all experienced client death somewhere in their career, some recently, some many years ago, some many times, some just once. But outside of her planned questioning, every one of them named that there was some splitting off between their responses as a human, as an emotional being, from their responses as a professional person, indicating some schism between those two ways of thinking about ourselves. Beyond that, it's well documented that mental health professionals report feeling ineligible to grieve. Like that's not a part of what professionals do. And in the worst of settings, for this particular issue, we found research where it showed people are interviewed and told by their managers that they're encouraged not to get attached. This particular comment comes from residential workers in a home where they offered mental health treatment for individuals with intellectual disability and co-occurring medical problems. So people who are quite frail and quite vulnerable and at risk. But as you can imagine, being told not to get attached will interfere with all kinds of work. And in that home, the workers actually report that the people who are helping them get through the loss of a client is the other clients as well, not their leaders, not managers, not a supervisor. And I think this is a place where we should exist, a place where we should be doing something to help people make sense. And so the advice here from us really is to, like Jackie's just displayed for us, is to tell stories, to share about clients who have affected us. Um, one of these stories for me is a woman I was working with in therapy for 4.5 years or so, who was looking at having an elective surgery that she had had once in the past. And learning about the surgery, learning about her health habits along the way, I began to feel quite concerned about whether she was actually able to manage the medical risk of this and was actually doing the things that I thought would keep her safer. And I thought it was quite ill-informed of surgery. And this really became present in my head in my sessions with her. I would feel frustrated. I would feel anxious about it. The more I thought about it in years past, I think that what made me frustrated was because I was worried that she would hurt herself, and I was unhappy with her decisions in those moments. But I don't step out of the therapy relationship. I don't call her physician. I don't do any of these things to block her, other than she knows, I think, my impression of it. But then she has this surgery and somewhat unexpectedly dies of medical complications of that surgery a short time later. And I'll share with supervisees sort of this story, my sort of reactions, including the ones that are not very um, pleasant to think through, that are painful. And then my own sort of sense of regret for how I had approached those final sessions, not knowing they were final sessions and wanting to sort of have those back to see if there's some different way that I could have been in the room. But of course, these personal feelings I have about it inform who I am as a professional and inform like how I respond to people in the moment. And those two things are not separate. And I think that sharing this and sharing my own experiences with failure, with loss, are really important to think through in these moments to give people some sense of how to be a full person in the work. And thinking in merit in particular, where you're inserting your own mind in your relationship with clients, we encourage the same in supervisions. Um, Now, to do this kind of thing, you also are sort of sometimes feels a little bit like you're stepping outside of the sort of established prescriptive bounds of a supervision relationship. So I would just caution people to stay within your scope, sort of avoid becoming a therapist to your supervisee, but to relate to them as a person, and to think about if you were in their shoes, how would you want a supervisor to act with you? Um, yeah. So following this, I find that in sort of the culture of mental health care right now, and maybe well beyond mental health care, but there is a really high and heavy focus on outcomes. So there are a lot of concerns about liability, and there was a really sort of interesting paper I ran into again in the research here that really describes therapists who anonymously were willing to admit that they had hospitalized people or that they had taken some restrictive action with a client when they did not think that that was the thing that would actually benefit the client most, that they were responding to their own fears about somebody being harmed, um, even if they personally viewed that harm to be unlikely and a different harm to be much more likely. But as a society here, right, we've decided that what the word outcome often means symptom reduction measures. And overall, we've decided that how something ends in clinical care should and does carry much more weight than how it proceeded, how it was during the course of it. And maybe some of this is just the human condition and how we think about these things as people. But it certainly is very active in this moment when we've just learned about a client's death. What can happen is if the only way that we are thinking about sort of mental health care in these really high risk populations is, how I think about myself as a therapist. If that is a compilation of these bad outcomes, then I'm going to think I am a bad therapist. There's a clinician on my team who's been doing this for near 20 years. And anybody who's worked for 20 years in a community mental health center with people who are particularly high risk, a team where high risk clients are referred regularly, one way to look back at your work is a long list of names who are not here anymore. People who could not be saved, people who could not be prevented from being murdered, from having terrible health habits and dying as a result of those, people who are, um, if we had just had more resource or just had more action or the system was more whatever, then um, but in this person taking some kind of self-appraisal of their own worth and value as a therapist, the product of their work over many years, if that's just a list of deaths, then this person is likely going to be quite demoralized. It's also the job of a supervisor to account for outcomes. And I don't think that that's wrong in and of itself, right? We should care that treatment benefits people. We should try to prevent bad things from happening. Uh, but it's not the case that we can prevent all these things. And this is not the sum total of our work as supervisors. So what we really hope to build when we're doing supervision, I think, as merit therapists, really supervisions that are oriented towards the supervisee as a full person and do have a relational focus. We really encourage people to think beyond symptom reduction as a way to evaluate care. Um, Clients oftentimes want things that everybody else wants, some feeling of connectedness, hope, optimism about the future, a belief in the possibility of recovery, a sense of their own identity, some meaning in their life, some empowerment. And it's very common that people don't enter treatment looking for symptom reduction. And that's not the only product we sell. There is another interesting paper along the research for this paper that shared the experience of clients who were homeless and who were entering a program for hospice for homeless clients. And many of them weren't seeking medical treatment, really, weren't seeking to become better, weren't seeking some kind of mental health treatment. What they named that they were looking for in one form or another was to be known, to deal with the fear of dying anonymously, to just being a body on the street that didn't mean anything to anybody. And so sometimes what we are offering people, whether we know it or not, intend it or not, is just to value them and to be thinking about them and to have a relationship with them. And so I'd like supervisors, we'd all, I think, do well as supervisors to carry the same kind of thinking into our supervisory relationships and consider the supervisee, again, as a full person, as somebody you have a relationship with who affects you and who you affect, who has some shared values, ideally, that you do, who has a story, who brought them to this kind of work, and who can use the death of a client as a natural inflection point in their life, just the way that many of us would or do. Um, and yeah, just to reiterate here, a longer life or a reduction of mental health symptoms is really not the only ideal here in care. But if we're not careful, this is the message that supervisees will get. This is a lot of what people leave graduate programs with. Their training is oftentimes very limited to just thinking about symptom reduction, evidence-based practices, and less relationally focused. And last year, this is a bit more situated after a client has died and the effect of this on a worker. But what's in the research here is that a lot of times after the death of a client, whether that's a suicide or another form of death, workers' willingness to support positive risk taking is very often reduced. I'm less likely to support the idea of my person going to an apartment if I have somebody who died in a house fire, right? I'm going to have thoughts about that. But the idea here is that we want to help people think through that and notice what is generating the more anxiety-provoking thoughts about this so that we can protect things like positive risk taking. A lot of times, in an agency setting, there is some task afterwards where, if not handled well, it really looks like we are having a meeting to decide whose fault it is that somebody died. Um, I think these meetings can be dangerous in that way, can certainly make mental health workers more afraid of their work, can make people less likely to, again, take risks that they should take with people. There's a complicated relationship that I personally don't quite understand between this citation here with Caputo 2021, that when people expect their clients to die by suicide, it interferes with their ability to mourn for them. And I couldn't quite make sense of that myself. Um, but it's an interesting thing to reflect on and think through. And so the recommendations here, right, are to try and always balance protecting someone's autonomy with their ability to self-determine. To continue, telling stories as a way of doing this as well. Um, we want to try with clients and with each other to really name when meaning making is interrupted. When risk management tasks are directly interfering with our ability to think through someone's story with them. It is really common, I think, as an agency, generally. I think this is true in many places, where we have many, many policies and procedures set up in how to respond to when somebody names thinking about suicide. And there's quite a bit less written there about how to help somebody make sense of why they're thinking about suicide or what place suicide exists in their life or any of the other kind of attendant features. But thinking about why somebody might kill themselves or what place in their life suicidal ideation has, I think helps us as clinicians with future assessments. And thinking about the story of somebody who died, it helps a great deal to approach our own incapacity to understand who will kill themselves and who will not, who will die in violent ways and who will not. And so sometimes what we want to do is consider these potential losses in advance. When we have a client who's living in a very, very risky lifestyle, I think it's important to think with supervisees about what might happen. but what might happen in a way that helps us understand who we were or who we can be in that process, whether we're trying to prevent that, whether we're trying to respect the person's autonomy, whether we are acting in those moments in ways that we'll be proud of, that will affirm our professional identities or not. And like I was saying a moment ago, one of the best ways to do this is, again, to sort of point back towards Jackie's talk, is to share stories. So one story I tend to share is of a client that I saw, again, for individual therapy for a couple of years, and who had fibromyalgia, was in really chronic pain, was working this really impossible factory job that she couldn't keep up with. She was on the verge of losing her house. Um, and who was then sexually assaulted right in that moment that she was really towards the edge. I was quite worried about her hopelessness, about how desperate she seemed increasingly with sessions. And so I did all the risk management stuff right. I offered her stay on a crisis respite unit. I routinely assessed suicidal thoughts, which she routinely denied. I tried to increase the frequency that I was seeing her, but she had so many barriers to coming in and I think maybe didn't view that as helpful, and so she didn't come more. And then a couple of weeks after this sexual assault, she dies of an opiate overdose. I think it's ruled an accident, but knowing her history, she had no history of drug use that she had ever disclosed to me, and I think was very likely a suicide. And I think back on this relationship as one where it's quite possible that I did all the right things from a policy standpoint. I think that was the review, that I did all the right policy kinds of things. But if I could try again, if I had made more efforts towards meaning making or towards something else, had taken her lead more, I wonder what would have happened or if I would have been able to. And maybe it's just that I couldn't have. But thinking about this over the years and sharing this with supervisees, and also sharing that I have a book of poetry from that client that I will occasionally look through and think about her and think about how she's affected me. Um, I think, again, sort of continues to show this way that people can blend together their professional and personal reactions. And sort of to a lot of the stories I've shared so far about me as a therapist, I do want to think also about one specific example here for a client who we'll call Ronnie, in which case I'm the supervisor. But Ronnie is discharged from a state hospital system into the care of my team. He starts working with a care coordinator who's a co-author on the paper that we put out. But Ronnie is a man in his late 50s, early 60s, who is diagnosed with HIV, has schizophrenia, has chronic drug use in his history, has just spent the last 2 or 3 years, maybe longer, in a state institution. And he's discharged, and out of the gate, things are pretty simple. We're working on getting him set up with the different kind of benefits he's entitled to, helping him figure out hobbies. My supervisee is really not needing a whole lot of support in doing these things that he's done a lot of times with people. But then their relationship deepens. They become, for lack of a different word, friendly with each other. He really starts to look forward to seeing this guy. There seems to be some kind of trust built up. He moves successfully out of our residential facility into a place with less support, and that seems to be going fine. His family remains sort of tangentially involved. But then there is an unexpected drug relapse. He stops all follow-up with the infectious disease providers he's been connected to. He starts missing appointments with us. And my supervisee starts getting calls randomly during the work week saying, "This is where I am." And he'll drop things and he'll go see him. And he's in these meetings quite anxious about, if I don't handle this really well, what's going to happen to you tomorrow, feeling a lot of pressure to get him reconnected with other things that he thinks will help protect his life. Um, and so we make lots of offers towards risk management and trying to help him just like get safe again. first voluntarily. Then there's some efforts to do a compulsory hospitalization, which are ineffective. Um, and as the supervisor in this moment, really my role is to help him think through what's happening. I'll share some of the stories I've shared with you. I don't make any efforts to help him feel less anxious, and I tell him so that I'm not trying to. Um, I shared my own sort of feelings of like powerlessness and of worry and of concern about what's happening here, but also offer him some praise about his capacity to be affected by his client and to manage that, and yet still calmly sort of get into the situation that he needs to be in. But then we get a phone call one day that he's found down in a park. He's unresponsive, and he's hospitalized at a local area hospital. He's got an infection that it seems he's not likely to fight. There's a terminal diagnosis is the outcome there. And so we think together about what we should do here. One of the offers on the table is to go together to see him on his deathbed, which the supervisee agrees to. So we go there together so that he can say goodbye and so that we can make ourselves um, available to the family a little bit, sort of within our professional guidelines and privacy kinds of stuff. And then after that, we take a walk together. We think about the whole course of things and what he needs for the rest of that day, whether he can return to work that day, whether he should go home. And think and just notice together that something really important has just happened. And then months later, when thinking about it again for the purposes of the paper that we put out, um, asking him to reflect on what went well or what was helpful or what wasn't, how dealing with losses this way has affected him. He really shares that clients after that moment felt more real to him, that he was at the same time, he had become more sensitive and less dismissive to medical risk, but didn't really feel like paralyzed by the fear that comes with that. And he had really kind of felt more affirmed in his choice to like work in this space in the world where people are oftentimes doing quite poorly. Um, and he felt more connected to the team. He compared that with a sort of rote ritual that he'd had at a previous mental health center, where they would get together as a group. Everyone would be called on to like say something about the client, but this was not his preferred way of grieving or dealing with that, and so it just didn't really map on to him and didn't help him the way that other things could have or did. And so there's just less attention in that space to the individual needs, and maybe viewed negatively as just an effort to sort of check the box or some response to not knowing what to do. So trying to come up with some concrete strategy instead. And so just thinking a little bit about future considerations, I think from both of our sections here, um, I think these things can make you a better therapist. Um, but there's very little guidance out there, and they can make you a better mental health worker in general. You don't have to be a therapist. I think can certainly help you be generally more open in talking about grief and loss. Um, More research is needed, and I think, as usual, we sort of wish this kind of thing was incorporated more directly into training programs, specifically from my view at the master's level, where there is no training on offering supervision, even though within a year or two, very commonly, these graduates are expected to have students or to provide supervision formally as program supervisors. And so I think here we'll transition a bit more into the more open part of the talk. Um, I'll leave these questions up for now for people if they want to share or reflect or share their thoughts about any of this or about their own experiences. Or if Jackie, you've more to add here.
No, I don't think so. I think just about like the more research needed. A lot of the articles that we found surrounding loss of clients are more comprised of like anecdotes or specific circumstances like suicide or hospice or terminal illness. And so I think, as we've talked about, and from the poll in the beginning, death is a part of life and could be a part of therapy too. And we work with just in mental health people who might be at elevated risk of dying earlier. And so I think maybe more generalized ideas about client loss and talking about them or working them into therapy or preparing upcoming therapists to manage those experiences, like Adam said, is really helpful, would be helpful. But yeah, we're interested to hear your reactions to the talk or thoughts that came up as we were going through this.
One thing that I was thinking about, and this isn't like a fully formed thought, it's just something that has like popped into my mind as you guys were talking, was like one of the clinics that I work in, for those of you who don't know, is the Older Adult Services Clinic at Eskenazi. And I think just by nature of the population that we serve, we experience like a higher volume of death in the Older Adult Services Clinic. And it's been an interesting experience as a supervisor in that clinic, where I think where I started thinking about this was, Adam, the slide where you talked about like expecting events like suicide to occur, like interferes with mourning. And I've noticed that a lot of times when there's a reported client death, there's kind of just a like, oh, I'm fine, or there's like not really much to talk about, or a lot of avoidance of talking about those things. And I don't know if that's like a function of, oh, well, we work with older adults, so this is just expected. And so they don't kind of allow themselves to go there or to become attached to the client or to have like a personal relationship with them. And recently I had a conversation with one of our care coordinators who, she kind of found herself reflecting on this, because someone that she had become pretty close with and had worked with for, she's been with our organization for about like close to 9 or 10 years now. So I think she's been working with this person for about that long. And that client passed away, and she kind of, it almost like snapped her out of this. I don't know if it's a fog or like, I don't know how she, or forget how she described it, but it kind of, she said it snapped her out of this, where she realized that she had become like far too desensitized to death. And like this death really affected her. And then she was reflecting back on like why others hadn't and like what happened there. And so I thought that was just a really interesting conversation. And I don't have any other fully formed thoughts outside of that, but just something I was thinking about as you guys were talking.
I think my biggest reaction to that one is just like, that sounds like that's exactly the task, though. That's right. So people sort of getting into some kind of autopilot ritual, which I think is harder to not do the more often you run into this, and harder to not do the longer you've been doing this. Uh, it gets a little bit like too regular or too easy. Which I think is always for me the challenge with like my really tenured staff who've been doing this a long time. It's always like particularly shocking when they go and they like find the client's body or something, which has happened. But other than that, a lot of the time what happens is they'll have supervisees who will remember particular deaths in a much more intense or like effective way, um, and others that don't seem to generate the same kind of reaction from them.
Yeah, I think those are good points, Kelsey, and thanks for sharing that. I think I too have worked with people who seem really unaffected by deaths or even like repetitive deaths. And I struggle sometimes to know, like, are you not as affected by this death, or is it more like you're avoiding talking about it, or it's uncomfortable, or should I encourage you to talk about it more? Like, when to know what is appropriate in those situations. But yeah, I do think it's true that some might affect you more, and that doesn't even necessarily mean that you were like closer to the person. Like the Nash who I talked about was probably the client I was closest to, but there have been other clients who have passed that have affected me less. But then I remember one who I'd worked with years ago and hadn't even seen for a while, and then found out they passed away, and that really affected me a lot. And I think like we talked about different, like, you know, where your head is at, or your personal experiences, or how you related to this client might impact them. So
Um, thank you for this presentation. I have acknowledged some client deaths, I think, with some of you, but as I was listening, I was thinking about how I don't think I've ever attended or participated in like a more formal discussion about the experience of losing clients. And so, Adam, I think you saying that there should be more of these discussions kind of really resonated because I have 15 years to reflect on and can't remember ever having a conversation quite like this. I did find myself thinking a lot kind of about the first question on the slide and how I think maybe a lot of what was shared relates to like what is our stance, what is our orientation to the work, how do we come to our relationships with our clients, and then even with ourselves and our peers and our supervisees, and that there's trying to really be like an actual human being, which I really think is core to merit of not being detached, I guess, kind of rejecting this idea that we are just this blank slate, as Jackie said, but also not being dominant and like imposing kind of a certain course of action that we think needs to happen, you know, getting overly kind of procedural with risk management, but being a real person in the room and connecting and trying to create something together in terms of maybe arriving at some sort of a shared understanding, a shared idea of a psychological problem. And I did find myself thinking about me trying to be human when, like, I'm thinking of a particular client who suicide is always on the table. And this is someone with very acute distress, times of active planning. And I elected to be a person. We've worked together for maybe 6 years, pretty much weekly. And at some point, I just shared, I would be very sad if you died, and I would miss you, and I would remember you, and I would think of you. And I think it was a really impactful intervention, although I felt some insecurity about it, like wondering, is that manipulative? Is it? But, I am appreciative that she has not died, but I think, yeah, just trying to settle in and actually consider, like, what if this happens, instead of getting so anxious about the possibility and then really like imposing. So anyway, I think, yeah, just so much of this presentation is about being human and being real with our clients in our grieving. And that can feel like really scary. Like we can feel out of control and vulnerable and fearful. So anyway, just kind of a collection of thoughts, but I really appreciate everything you're sharing.
Something that came to mind was so my team works closely with folks who are unsheltered. So a lot of times we find out when people have died in very just random ways of finding out. And it can be hard. It can feel like whiplash, and it feels like it's hard to keep up with. But something that I've appreciated that the community does is CHIP holds a memorial every year for neighbors who have died who might not have any supports in the community or family members, stuff like that. And last 2 years ago, we were able to attend as a team because we had quite a few people who had died. I wish that there was more room to do commemorative things like that at work and professional settings. It was a good way to start conversations in individual supervision. And it was a good way to allow some space for us to just grieve together as a team, but also maybe think about things that we hadn't been prompted to think about before if we didn't want to talk about it in supervision.
Yeah, when I think about those kinds of events, for my just personal experience of them, I find that the most useful thing for me is like knowing that they exist. Not like I don't care to go, I don't care to participate. I don't want to like say in front of people that I feel really sad about. Oh, not talking to this guy who's I've had the most frustrating conversations of my life for 5 straight years every week, Um, but I think that for me, the value of those is the permission. It's some sort of formal statement that it is expected that you're supposed to notice and be affected by these things. And so, sort of in lieu of like agency policies where we're allowed to like block time for grieving or like use an internal bereavement policy to save people from using time off or something where we don't have those kinds of supports. Uh, Really like the supervision sort of stands in for like us to formally say like you're supposed to feel this. Uh, yeah, or we're sort of similar to Becca's comments, right? I will say to supervisees, and in some ways, maybe differently phrased to clients in the same way, but I'll say like I'm having a hard time tolerating. I have predictions about what's going to happen here, and I have a really hard time thinking about it, or um, I'm really sad or scared about this, um, or yeah, I've certainly told clients that I would miss them if they died many times. Yeah.
I think those types of memorial things serve to acknowledge the person, and that is part of why it's helpful, like acknowledge them as human, and that humanness factor, like Becca was talking about. I think people with mental health struggles can be seen as like different or less than, and so giving that dignity of having a memorial for them or acknowledging that their death was important and their life was important, can can help people get closure or help them feel better about it or not feel as like discouraged. I think we also have we have a yearly like remembrance event where they share the names of clients too. I've had people like pass away in groups and then they just never come back to the group, and it's questionable if you can like tell the other group members what happened. And so Eskenazi having that event to be able to just like share the names of people that have passed is another small way to acknowledge them and their like existence.
I think something else that stood out is integrating the thought of like how I might feel comfortable talking about grief or like a client's death or just some type of uncomfortable thing could be different and is different from a supervisee's. I'm specifically thinking about a time where a client had experienced multiple strokes, ended up in a nursing home and having to end services. Uh, my immediate reaction was to visit this client, to say goodbye, to be able to like start that grieving process too. And then some supervisees' reaction was to avoid it. So balancing what I have done or what I would want to do or what I did versus what supervisees don't feel comfortable doing, even if there is a space to be able to do those kinds of things. I also am just having running statements in my head, but thinking out loud was like, well, how do I manage a situation like that? But I think it's again the slides where it talked about like having the openness and thinking through the grief together. If there is wanting that need of avoidance, but also wanting to, yeah, just balance all the roles. I'm just thinking out loud.
I wonder if some of this is kind of getting back to the question about how this fits with merit, but like, I don't know how you fully engage in meaning making in life if death is not part of those considerations. It's such a key question for all of us. But maybe in terms of the supervisory response, trying to be respectful of different people having different agendas and not insisting that a supervisee handles it the way we want them to, or, obviously within the bounds of whatever acceptable uh, practice is. But I think just taking kind of an individualized approach to creating some space to try to help people think things through without telling them how to behave, whether it's our clients or our supervisees. Yeah, I don't know. I had a couple of other thoughts that were going through my head. I think I had 3 clients that die on my teams last week, which was an exceptionally high number, but I think it just speaks to the frequency with which we learn of deaths on some of these teams. One of whom I knew quite well years ago, and the other 2 I had never met in person. But some of it is like, I don't know, for me, just constant confrontation with suffering and tragedy in the community in a way that I probably wouldn't have encountered as intensely if I chose a different line of work. And then figuring out how to use that as some kind of opportunity or responsibility versus just letting it like beat me down and make me have to erect some kind of really rigid defense. I don't know. And maybe one related thought that kept going through my mind. I can't remember the exactly how he describes it, but there's an Otto Will paper from decades ago where he's talking about love. And I think probably because there have been so many therapists with terrible boundaries or just like fears of regulation that like the word love doesn't get used as much in thinking about like what we do as therapists or like our own humanity. But I think there is something about this that is really just humanizing to both therapist and client, and being able to like recognize that maybe some of what we do is to be able to offer a certain type of love to people. And that's what is healing about psychotherapy. But then how to translate that without it becoming some sort of weird thing that freaks people out or leads people into making like ill-advised decisions in their relationships with their clients. But I do think there's some truth to it that this is if we allow ourselves to really be open, that it will inevitably come up that there is some kind of love that occurs in this work. I don't know.
Yeah, this topic, no matter how much time I spend thinking about it or dealing with it, it is always something that makes me both feel heavier and like my head is spinning at the same time. And so I've just got that going on right now. And I think I might not be the only one.
I think I feel that way now, and I was trying to think of something to say, and I think I just feel like this talk was really like powerful and helpful for me, and I just am thinking about a lot of things, and um, I think it's just helpful to like not forget our own like humanity with things like this, and it's something that just can be incredibly hard, and not just like brushing off death and just saying, okay, well, I have to go on my day being a therapist now. So I guess just thank you for this. It's really helpful.
Jay, your comment about love reminds me of something Jeremy said in the last talk. Like I think about it's, I do think it's relevant, and he, I won't remember it perfectly, but talked about kind of needing also though guarding against sentimentality, and that's kind of like another maybe risk. But I'm just maybe sharing that's come up because it might feel, yeah, like it's almost like a taboo word. I feel at least to be used. Um, I guess I just want to share just adding maybe another kind of client loss that I don't, I mean, it's not actually different, but I don't know if others have had this experience much of concluding work with someone, maybe a planned ending, or maybe they just drop off, and finding a narrative in my head, like creating one that maybe helps me deal with that ambiguity. Maybe imagining that they're doing okay, or whatever their last risk was has worked out, or maybe imagining still that they're struggling, but kind of that hopefulness for the best. And then later in time, learning not that they had died around the time of termination, but a couple years down the road. And I have found that to be quite difficult because um, there's another, there's a whole bunch of other ambiguity that then gets, that I have to contend with. Like what happened? Was there years of suffering? I might find out like months after the death. And so any sort of, if there was a potential for any sort of shared mourning, or even if I mourned on the periphery, I may have missed those opportunities. Bringing up maybe similar questions of could I have done differently? What could I have done differently? How could I have not been fired and still had the chance to keep working with this person? And a lot of that too, I mean, it could certainly become grandiose in terms of, maybe thinking I could have saved someone. But I do find that hard and lonely, I guess, to be aware of that. And then sometimes even feeling like a little, maybe that disenfranchisement of, can I even bring this up in my clinic, to be like, hey, remember that person I worked with years ago? And I just heard through the grapevine or came across this information. And that person might not be as like kind of salient to the clinic anymore. And it's just lonely. And I find that those people kind of bounce around in my head, um, maybe more so than, a time I can think of when I was more actively working with someone who then died. So I just thought I'd share that and imagine other people have had similar experiences.
Yeah, absolutely. Yeah, we were moving and I was packing things up with newspaper and found on the page that I was using a list of like people with unclaimed property at the coroner's office. And there were three names that I knew on that list. Only one I had known before that had died. And it does, I think, give me that same sense that you're describing. Like, well, what do I do with that? Who do I even tell? Thankfully, I work in a very supportive place and I had people I could tell about it and who understood. But then also, this is like a week or two ago, a rumor had reached our like front desk staff that a client who had used to cause lots of disruption in the clinic might have died. And so the security officer was like walking around the building asking people like, "Hey, do you know anything about this?" Because they're all trying to figure out what happened to this guy who I like made all their lives harder a lot of the time, but who they had also seemed to form some kind of connection with too, because they all wanted to know, and so it's not just us, and this is like it's a need that's out there.
Yeah, Becca, when you were talking, I was thinking that like termination with a client could feel similar to them dying in the sense that like we focus on the alliance or the dyad or the relationship, and then when that other person is no longer there, like we are just left with the half of the dyad and just feel like, what do we do with that? How do we make that meaningful? How do we hold that in a way that is, I don't know, like feels important?
I wanted to also say thank you for I think it's a courageous talk to initiate. And I have had a client who has died by suicide. It was a very violent death. And for me, I found a lot of these similar reactions, a strong pull to take away his agency, to make sense of the end of his story. And I think for the first question, how does this fit with merit? As you guys were all talking, I was able to kind of put together some thoughts, but there's this pull to want to finish the story in my mind. And I hear something similar that you all are experiencing. And I think that fits well with merit. As you know, merit talks a lot about letting a person's story be fragmented and being able to sit with that distress and disorganization. And so I think the storytelling aspect of this talk especially sits well with merit and sits well with how I tried to make sense of this person's loss, and how I also tried to continue a story about his life in my mind through, eating his favorite food or listening to his favorite songs, and hoping in some way his story continues in at least someone's mind. So again, thank you, guys.
Yeah, thanks for sharing that, Jackie. I relate to those things a lot.
Yeah, I think that my coworkers in this meeting already know this about me, but usually when I'm more stressed, my natural inclination is to like become more decisive or controlling of things. Um, and thinking again about how this overlaps with merit is that like learning to deal with these kinds of losses and learning to do merit, it has been the same process for me, and like being okay with joining things in the middle, okay with things when they don't make sense, offering less control and less direction, because those things actually don't help in these kinds of circumstances at all. And so my typical way of coping doesn't work, which also I think helps me be a bit more empathetic to people who cope and deal differently. But I don't think I'll be done thinking about this anytime soon. But as I think we wind down here, I just want to say thank you to everybody. We were looking forward to doing the talk in this version where we had a half hour at the end to just like chat with people about their experiences, and that's been really nice. So thank you all for sharing your thoughts.
Yeah, thank you for sharing your experiences as well.
Well, thank you guys both for this talk. It's really well received, and I think kind of provoked a lot of thought and memories, and we did our own storytelling on here. So that was really nice. All right. Well, if there's not anything else or any final thoughts, can go ahead and log off. We will have our next quarterly webinar in May. And that will be Laura and Courtney talking about merit and working with folks with personality disorders. So hopefully you all will be able to join us for that one too. Thank you guys again.